So this is a very good article from Australian Dental Journal, which clearly says that physiological studies have shown that infection is often limited to the coronal chamber of the root canal system of the caries exposed pulp. Therefore, if the caries process alone is removed and infected pulp is amputated, the remaining pulp tissue, healthy tissue, is capable of repair. So this is the fundamental basis of vital pulp therapy. So did you understand the statement? What they say is, in a caries process, only the infection will be limited only to the coronal half of the pulp chamber, whereas the remaining pulp will be remaining vital and functional. So what they recommend is remove the infected part alone and keep alive the remaining tissue so that it helps to repair and keep the tooth vital. Even if our vital pulp therapy fails, it is always easy to perform a primary root canal treatment rather than doing a re-root canal treatment. I think it makes sense. Instead of doing a re-root canal treatment, which is going to be very difficult, there can be instrument fractures, there can be ledges, there can be perforations the previous dentist would have performed. So doing a re-root canal treatment is always difficult than doing a failed vital pulp therapy. If our vital pulp therapy fails, we can confidently do a primary root canal treatment. So now vital pulp therapy is considered as an accepted treatment modality by the American Association of Endodontists and European Society of Endodontology. So now this is next case where the 13-year-old boy came with a chief complaint of pain. So on seeing this picture, just like the doctor asked, we may think it is a case of RCT. But actually, considering the age of the boy, we can perform a simple vital pulp therapy. So under local anesthesia and rubber dam isolation, the caries was removed, and at one point the pulp got exposed. The pulp exposure was directly capped with biodentin. Biodentin is a wonderful calcium silicate based material which has got wonderful properties to heal. So after placing biodentin, I have completed the restoration with routine composite. At this juncture, I would like to highlight a point that biodentin is the only bioceramic material which can be etched and bonded. MTA cannot be etched and bonded. So biodentin has got the advantage of MTA being bondable to composites, being friendly to composites. So we don't need a separate layer of glass ionomer or a ionoseal over the biodentin. Directly you wait for 12 minutes. The setting time of biodentin is 12 minutes. After 12 minutes you etch, you bond, directly you finish the case. The patient is fine. He is 13 years old, his molar is again functional and vital. So this is the post-operative picture. Now let me highlight some of the important properties of biodentin. Biodentin is a potent anti-inflammatory agent. Number 2, it sets in the presence of blood. Number 3, it is osteoinductive, osteoconductive and osteogenic. Osteoinductive means biodentin has got the property of attracting the mesenchymal stem cells. Osteoconductive means biodentin by itself acts as a scaffold for the mesenchymal stem cells to come and sit. Osteogenic means biodentin can convert the mesenchymal stem cells into odontoblast-like cells. So odontoblast-like cells will produce dentin-like structure. Dentin vera, dentin-like structure vera. Odontoblast vera, odontoblast-like cells vera. So these are some of the important properties of osteoinductivity, osteoconductivity and osteogenicity. Biodentin satisfies all the 3 properties. So we all think biodentin is used only in cases of perforations and endodontic mishaps. Never. Biodentin is primarily a vital pulp therapy agent. And secondly, the advantage of vital pulp therapy is that it is highly cost effective. In today's cost, the cost of one root canal treatment followed by a crown is minimum 10 to 12,000 rupees in city like Chennai. Somewhere it even goes up, somewhere it comes down. But the cost of vital pulp therapy can be winded off between 6 to 8,000 rupees or even lesser depending upon our experience and our facilities. It is highly cost effective for the patient, highly beneficial for the patient because we are preserving the vitality of the tooth. So this is a case of kissing lesion between 6 and 7. The patient himself is a senior periodontist who came with a chief complaint of foot lodgement between his 6 and 7. So this is the radiographic picture. There are no signs of periapical pathology. The PDL looks good. The patient has just complained of foot impaction and there is loss of bone between 6 and 7. So under local anesthesia and rubber dam isolation, a proper class 2 cavity was prepared. So the key point in preparing a class 2 cavity is that the DJ must be crystal clean and clear. So this is where it determines a strong peripheral seal zone. It's called PSZ. So if we want a good bonding, we need a clear DJ which is devoid of caries. So this is the post-operative picture. So here I have used an injection molded technique of composite where I have made the composite melt at 68 degrees Celsius followed by injecting into the bioclear matrices. So here you can see the saliva is happily playing seesaw in between 6 and 7. See, you can, by seeing the picture itself, you can understand how gum friendly, how tissue friendly the material is. So you can rely more on composites than on our PFM crowns. So again, what are the key points in this restoration? I have restored back the occlusal embrasure. I have again restored the gingival embrasure. Thirdly, I have given a tightest contact so that the foot doesn't impact anymore. Fourthly, there are no overhangs because the bioclear matrices are anatomical matrices. And fifthly, composite by itself is friendly to the caul tissue. So the caul tissue never gets irritated. And finally, the patient had no more dentinal hypersensitivity. So these are some of the achievements which you and me can do by performing a proper class 2 cavity. So again, the doctor himself is happy. He is happily able to chew his food without food impaction. He is able to enjoy both hot and cold food. And the last one, dental hypersensitivity, can be avoided if we are well versed with a procedure called immediate dentin sealing, IDS. If we know to perform a proper IDS, we can easily tackle dentin hypersensitivity. So this is my final case of vital plug therapy. A 9-year-old boy. So this was way back 4 years, 3 to 4 years back, where I hadn't had the opportunity to buy sophisticated cameras. So this is a 9-year-old boy who had a complaint of pain, proper pain, spontaneous pain in his lower 6. So under rubber dam isolation and anesthesia, I was not able to achieve hemostasis at the level of pulpal exposure. So I had to dig in more to remove the infected pulp tissue throughout the coronal pulp chamber. So I had removed the pulp chamber entirely from the coronal half of the tooth. Only then I was able to achieve hemostasis. Now the next question comes, how to achieve hemostasis? People are afraid of sodium hypochlorite. Actually, sodium hypochlorite is a very beautiful material if it is used properly. Take a piece of cotton, soak it in hypochlorite solution, thoroughly pinch it so that there is no drop of sodium hypochlorite. Take it and place it over the site of bleeding. Give a strong pressure. After 5 minutes, you can see that there is 100% hemostasis being achieved. Even after that, if there is no hemostasis is able to achieve, only then we have to go ahead with pulpectomy or root canal treatment. So this is how we have to achieve hemostasis clinically. So now this is the immediate post-op picture which I had taken around 3 years back. See, way back then the premolars were under maturation, and see, this was taken around 3 years later, where the premolars are totally matured and my root is almost completely formed in the molar also. And secondly, in the immediate post-op picture, we can see 2 gradients of radio opacity. The upper one is a glass ionomer, type 9 glass ionomer. The below one is biodentin. So we can clearly see 2 different radio opacities. Whereas in 3 years later picture, actually here it is not very clear. See, the picture is the main part of my presentation, only then we will understand. So,
picture is shared in the group now.
Otherwise nobody will
For
understand.
permission.
So in the post-operative picture, to my surprise, I was able to see the biodentin and root dentin were of same radio opacity. which means biodentin has become an integral part of the root canal system by becoming the dentin by itself. I told you, no, it is osteoconductive. So, Chandramukhiya ninne, Chandramukhiya marne mari, the biodentin became like a dentin, like a coronal dentin by itself. And another important point, the patient responded positively to cold vitality testing. That is the most surprising part in this case. I have removed the entire coronal pulp. I have placed biodentin. Above that there is glass ionomer. After 3 years, I placed the cotton, cold cotton on the specific tooth. The patient was able to perceive the chillness which I had placed on the tooth. So this shows how beautiful biodentin, a material by itself. Now the patient has come. Actually for the 3 years the patient didn't come. Only now he had come for follow-up. He will be now receiving an overlay, Emax overlay above the tooth. So now what are the clinical strategies in class 2 preparation? It is just going to be another 10 more minutes. I would like to complete my presentation. So these are the main pillars of any class 2, be it layering technique or be it bioclear technique. We need five pillars to do a proper class 2 restoration. You can take a picture, it is very useful clinically. Number 1, we have to remove the biofilm thoroughly. Studies have shown that when there is biofilm, without removing the biofilm, if we are going to perform a composite restoration, the bond strength achieved is not to its full extent. So always remove the biofilm, and biofilm can be seen with the help of tri-plaque gel from GC. I request everyone to buy that material from GC. So after we remove the biofilm, the tooth now becomes amenable for bonding. So only after you remove the biofilm, your composite restoration can achieve its full bond strength. So number 1 is biofilm removal. Number 2 is cavity preparation design. So gone are those days where we used to give a perpendicular preparation of GV plaques. Today it is all about modern cavity preparation techniques, which I will be explaining you shortly. Thirdly, the choices of matrices and wedges. You have to choose correctly and wisely. Fourthly, you can do either a layering technique or an injection molding technique. And finally, you need a good polish. A polished restoration can never attract plaque. Only when there is plaque, there will be secondary caries. So ensure always that your restorations are super duper polished. So this is a picture which clearly shows how a traditional plaques cavity preparation can create micro cracks beneath. So this is the reason why most of our GV plaques cavity preparation fails. I am not talking about amalgam, it's the cavity preparation design. So this 90-degree preparation usually results in micro crack formation, which leads to micro leakage, which leads to secondary caries, which leads to unhealthy cord tissue, and overall it may lead to non-vitality. So the point here is, what I would like to mention is that we must start avoiding 90-degree preparations, which was conventional. We have to move on to modern cavity preparation designs. So with a small illustration, I would like to explain the cavity preparation. With that, the session gets over. Always use a tri-plaque gel from GC to identify the plaque. Once the plaque gets identified, you have to do something called sand blasting. Sand blasting is done with the help of water and 29 micron alumina. As a combination, when you blast the tooth surface, it removes the biofilm. And before we start a class 2 cavity preparation, it is highly recommended to use a wedge guard so that we do not nick inadvertently into the adjacent tooth. So I will show what is a wedge guard. This is a wedge guard. So when we place a wedge along with the guard, you are guarding the adjacent tooth. We do not have to unnecessarily see how many of us use this. Many of us won't use this. We don't even know if there something exists like this. But after constantly using this, I understood that I myself have inadvertently, torn this matrix, torn this wedge guard. So even the thinnest of the diamond burr can nick the adjacent tooth. So it is always necessary to have a wedge guard with you in your practice. So you can make a note. So till now I have told you to buy truck plug gel, aqua care, air pressure unit, and carries detector dye from Curare. And there are a lot of wedge guard, especially from dense ply. It comes in two sizes: 4.4, 4.5, and 5.5. So they are really good. So, so after identifying the carries with the help of the dice, you can use something called SR11. S stands for straight, R stands for round. Straight rounded burr number 11 can be used in a buccolingual direction. We need not have to first remove the contact. First expose the carries on the occlusal side. Always it is recommended to perform such procedures under at least 3x magnification. So under magnification, always use a round carbide burr. From SS White we have got such beautiful burrs. It's called straight surgical length SLFG friction grip. SLFG 0406. These are common sizes which I am using in my practice. Only a carbide burr can cut dentin in the best form. So once my caries is being removed, the DEJ becomes crystal clear. So this is dentin, this is enamel. So this junction must be crystal clear for my class 2 composite to be successful. And now coming to the contact breaking. Contact breaking must always be done under a wedge guard. And number 2, there is a special burr from a company called Strauss. I want everybody to buy that and use it. 5 burrs comes to rupees 800. So you can buy that burr. It gently, precisely cuts the proximal contact. So this particular burr from Strauss is really good. And finally, you can use a flame shaped red coated diamond burr to give you a gingival bevel. And this is something called a Callia lily burr. I think many of you would have been aware of this burr. This Callia lily burr will give a morning glory flower look for your cavity preparation. And finally, these are called finishing and polishing strips. See, I think I have given the image, but we are not able to see. So finishing and polishing strips from 3M is really good. You can use it to make your proximal surfaces super soft and smooth. Because only a smoother and a softer surface can achieve better bond strength. So this is the overall preparation design. If you see in this picture, overall there is 360 degree of 2 mm enamel surrounding the cavity preparation. So this 2 mm of 360 degree enamel is going to make my composite restoration 100% predictable, because composite loves enamel. Enamel addition is predictable. So more than dentin addition, this 2 mm of enamel surrounding the cavity is going to make my composite restoration successful and predictable. So this design of 2 mm enamel 360 degree around the cavity is called radius wall preparation technique. So this radius wall preparation technique is the basis of modern cavity preparation. So these are 3 examples. Number 1 is your conventional GV blacks preparation, where the walls are in 90 degrees. Second one is box only preparation. Again in box only preparation, the walls are 90 degrees. This third one is your modern cavity preparation, where they have followed the radius wall technique. So these are the pillars of modern cavity preparation. How to achieve this? You have to start from any one of the cavo surface margin, go and form a curvaceous arc. You have to extend the arc occlusally till the cuspal tip. This creates a compression zone. Only a compression zone is advantageous for composites. Only then the interface will be intact, it won't fracture. And by doing all this, even if there is micro crack present beneath, it will be protected. So this is the foundation and basis of modern composite cavity preparation design. So this concept says use 70% enamel and 30% dentin. So to summarize my presentation in a nutshell, always use a cold tester to identify which is the correct case. Secondly, ask for spontaneous pain history. If there is spontaneous pain, there is no doubt we have to perform a root canal treatment. Number 3, always study the IOPA thoroughly. If there is periapical abscess or periapical lesion, never try vital plug therapy. And fourthly, we have to explain the patient about chances of post-operative pain after vital plug therapy. If needed, it may develop into root canal treatment. So patient counseling forms a very important role in choosing a patient for vital plug therapy. I usually tell my patients that if the pain comes after my procedure, I will give you a discount of 25% in the RCT and crown. So this is how we can explain the patient. Always use an upper dam. Always ask for 1 day, 1 week and 1 month follow-up. A good restorative dentist, if he does his work properly, he will attract all on 4 or zygoma cases easily. So just like that, people don't trust a doctor. Only through constant, sincere restorative work, I feel we can attract Invisalign patients, or bigger cases comes to us only if we perform small cases precisely. So tiny drops make big ocean. So I'm actually happy to say I'm training people for this exclusively for deep caries management. So those who are willing to undergo, I am there. I am telling proudly that I am taking training people for this deep caries management. So you can follow in Instagram. This is my ID. So I thank Rajsekharan sir and the IDA team and CDE team for giving a wonderful opportunity to share my knowledge in the field of restorative dentistry. Thank you so much.